You are staring down a swollen, angry hand at 2 in the morning in a chaotic ER, right?
Yeah.
And the ER attending is pushing you for a quick bedside incision so they can just discharge the patient.
Yeah, we have all been there. It is a huge trap.
It really is.
Yeah.
But the stakes are just infinitely higher. Mismanage a hand infection, and you are looking at lost productivity, permanent disability, and, well, a ruined grasp for your patient.
Absolutely. The margin for error in the hand is essentially zero.
Exactly. So today we are doing a deep dive to build a functional roadmap for saving hand function and preventing ischemia. We are talking clinical pitfalls, diagnostic traps, and real surgical pearls.
I love it. And before a blade ever touches skin, you really must understand the hostile, pressurized environment of that swollen extremity. I mean, the structural reality of the hand dictates your entire initial workup.
Right. You have to evaluate the extent of erythema, locate any distinct abscess, check active and passive range of motion, and this is huge. Immediately assess immune status.
Oh, for sure. Finding out a patient has poorly controlled diabetes, HIV, or is on immunosuppressive therapy, well, it changes the game completely.
Your threshold for taking them to the operating room drops drastically.
Exactly. That structural reality is completely unforgiving.
Just like you wouldn't miss a subtle ptosis in a facial consult, you really cannot afford to miss the early warning signs of compartment pressure in the upper extremity.
That is a great comparison.
Think of the hand's fascial compartments, like a high-rise building, right, where the fire suppression system is totally offline. Swelling in one closed room rapidly expands. And because those walls cannot yield, that pressure crushes the vital cables running inside.
The tendons and nerves.
Exactly. That pressure leads directly to ischemia and necrosis.
Which is why, our early management focuses on offloading that pressure and establishing a baseline. For early, uncomplicated infections, you splint them in the intrinsic plus position.
Right. So that means the metacarpophalangeal joints flexed and the interphalangeal joints extended.
Correct. You prescribe strict rest, aggressive elevation, and empiric antibiotics. But, and here is a common pitfall, you only initiate those antibiotics after you grab your wound cultures.
Yeah, because hand infections are notoriously polymicrobial. You need empiric therapy that covers a broad spectrum until the lab gives you a targeted target.
Exactly.
But let's talk about the reality of being on call. Sometimes you are stuck waiting for an operating room. The board is full, a trauma just rolled in, and a delay is unavoidable. You have an abscess with clear fluctuance just sitting in the bay.
Well, you do not just wait. You aspirate that abscess cavity right there in the bay with a large bore needle.
You just go for it.
You have to. You have to reduce those compartment pressures immediately. Lowering the volume inside that closed space restores microvascular perfusion to the tendons. It prevents irreversible neurovascular injury while you wait for your surgical time.
Wow, okay. So once we finally do get to the OR, the setup traps are everywhere. If you were going after a deep space infection, you really need an axillary block or general anesthesia.
Oh, 100%.
Digital blocks are fine for fingertips, but you absolutely cannot chase a deep palmar abscess on a digital block. The patient will be jumping off the table.
Right. And the tourniquet setup is another place where I see residents make critical, unforced errors. I mean, we use a pneumatic tourniquet to maintain a bloodless field, right? So we can actually see the delicate structures we are trying to save.
Makes sense.
But in an infected field, you never exsanguinate the extremity by compression. Do not let anyone wrap an Esmarch bandage tightly up that infected arm.
Because that mechanical pressure is just milking the purulence proximally into, perfectly healthy tissue planes.
Exactly. You exsanguinate by elevation and gravity only. You just hold the arm up for 3 to 5 minutes, then inflate the tourniquet.
Simple but critical.
Very. Another common pitfall is local anesthesia. Never infiltrate lidocaine or bupivacaine directly into an area of cellulitis.
Because of the acidity, right?
Yes. Infected tissue is highly acidic. That low pH environment completely ionizes the local anesthetic molecule, which prevents it from crossing the nerve membrane. It simply does not work.
And plus, the volume expansion of the fluid physically spreads the infection further along the fascial planes.
Exactly. So if your initial setup is dialed in, you still have to navigate the most deceptively simple part of the hand, the fingertip.
Oh, man. This is where an on-call resident's overconfidence usually creates a functional disaster.
It really does.
Let's start with acute paronychia.
Right. So this is the classic runaround infection hitting the soft tissue folds surrounding the nail plate. Usually, it is a staphylococcus infection driven by nail biting, aggressive manicures, or poor hand hygiene.
You see pain, swelling, and erythema localized right in the perionychium.
Yep. Initial management is warm soaks and oral antibiotics.
But when that progresses to a true abscess under the eponychial fold, you have to open it. I always tell residents to pay extreme attention to their blade angle here.
Yes, in real life, you must angle the blade away from the nail bed. If you accidentally score the germinal matrix of the nail bed with your 11 blade, that patient will grow a split-ridged, deformed nail for the rest of their life.
That is a nightmare.
It is, and if the abscess has tracked deep and extends under the nail plate itself, part or all of the nail has to come off to allow for complete unroofing of the cavity.
Okay, so that is acute. Chronic paronychia requires a completely different mindset. You see this constantly in dishwashers, bartenders, and waiters.
People with chronic, repeated water exposure.
Exactly. The pathogens shift away from purely Staph aureus to mixed flora, including Staphylococcus epidermidis and very frequently Candida albicans.
Right. And the tissue is boggy, chronically inflamed, and it lacks a discrete pocket of pus. You cannot just poke this and expect it to resolve.
So what is the move?
You have to alter the anatomy. You perform an eponychial marsupialization.
Okay.
You excise a minimum 3 millimeter wide crescent of skin and subcutaneous tissue parallel to the eponychial fold. You run that incision the entire width of the finger.
Wait, so you are intentionally leaving a large defect?
Yes. You leave that wound completely open. The patient goes on a strict regimen of warm soaks with dilute povidone iodine until the chronic inflammation subsides.
Fascinating.
And as long as you stent the eponychial fold appropriately, usually with a small piece of xeriform or even the original nail plate, the new nail will grow back normally.
Let's move to the volar pad, the felon. This is a deep infection in the soft tissue pulp on the volar aspect of the fingertip. But I want to set a very real scene here.
Go for it.
It is 3 a.m. The ER doc is pushing you to just lance a suspected felon at the bedside so they can clear the room. But you look closely at the swollen pulp and notice a cluster of tiny clear vesicles.
Oh boy.
How do you avoid the absolute nightmare of slicing into a herpetic whitlow?
You step back and take a meticulous history. Herpetic infections mimic bacterial felons perfectly if you miss those vesicles.
And who usually gets these?
In pediatric patients and healthcare workers like respiratory therapists or dental hygienists, it is usually herpes simplex virus type 1, inoculated from the oropharynx.
Right.
In adults, HSV type 2 predominates from direct genital inoculation. It has a 2-week incubation period, followed by severe throbbing pain that often seems way out of proportion to the initial mild swelling.
Then the giveaway appears. Those small 1 to 2 millimeter vesicles erupt on the volar digit. Over a few days, they coalesce to form larger, cloudy bullae.
Yes, and if the clinical picture is ambiguous, a zinc smear showing multinucleated giant cells is diagnostic.
Good to know.
But the surgical rule for a whitlow is absolute. Do not operate. It is a strict hands-off diagnosis surgically unless there is a confirmed secondary bacterial superinfection.
Because if you incise a herpetic whitlow thinking it is a routine bacterial felon,
you risk disseminating that virus directly into the systemic circulation, and you can cause a severe viremia. It is a massive unforced error. You treat it with dry dressings, oral acyclovir, and thyme.
Okay, let's assume you have ruled out a whitlow and you have a true felon, a classic volar pulp abscess. The architecture of the distal finger pad is totally unique, right?
Completely unique.
You have multiple vertical fibrous septae that anchor the dermis of the pad directly down to the underlying distal phalanx periosteum. That rigid architectural grid is what gives the fingertip the stability to handle the sheer force of a heavy pinch grasp.
Exactly. So when you drain a felon, you need to incise directly over the point of maximal fluctuance. A common pitfall here is the blind sweep.
What happens?
Well, if you take a hemostat and blindly sweep it through that volar pulp in an attempt to break up loculations, you will systematically destroy too many of those fibrous septae.
So you clear the infection, but you leave the patient with a mobile flail, completely non-functional fingertip pad.
Right. The skin just rolls right off the bone when they try to pick something up. Their pinch grasp is ruined.
That is devastating.
Furthermore, your incisions must never cross the distal interphalangeal joint flexion crease. If your incision crosses that crease, the resulting scar tissue will cause a permanent flexion contracture of the joint.
So when those distal infections get ignored, or, the patient delays care, the bacteria do not just stay in the pulp. They track proximally and breach the closed flexor tendon sheaths.
Yes, now we are talking about pyogenic tenosynovitis, and the risk shifts from a useless finger pad to total finger fibrosis.
Usually this stems from penetrating volar trauma to the proximal or distal interphalangeal joints.
Yeah. A contaminated foreign body, a rose thorn, or an animal bite. Pathogens are typically Staphylococcus aureus or beta hemolytic streptococcus.
And in sexually active populations, you occasionally see it as a manifestation of disseminated gonococcal infection.
That is right.
I always think of the flexor tendon sheath like a high-performance piston inside a perfectly machined engine block. It is a flawless gliding mechanism.
Great analogy.
Puss inside that closed space acts exactly like throwing a handful of sand into that engine cylinder. It rapidly causes friction, mechanical failure, and profound fibrosis.
Which is why delaying treatment guarantees tendon necrosis. You have to recognize Kanavel's cardinal signs immediately.
Let's run through them.
Okay, so 1, the finger is held in a semi-flexed posture. 2, you see symmetrical fusiform enlargement of the entire digit. 3, there is exquisite tenderness along the entire volar course of the flexor tendon sheath. And 4, excruciating pain on passive extension of the finger.
That last sign is the most sensitive. Let's explain why to the listeners. When you passively extend that semi-flexed digit, you are mechanically stretching a highly inflamed pus-filled sheath to its absolute volumetric limit.
Exactly. The pressure spikes dramatically, which is why the patient will practically leap off the bed.
If you see those signs, you are heading to the operating room for a formal washout. But the surgical balance here requires finesse, doesn't it?
Oh, absolutely. The goal is copious, high-volume irrigation of the tendon sheath to clear the bacterial load. However, you must achieve that with absolute minimal exposure of the tendon itself.
Because that flexor tendon relies on a very delicate, tenuous blood supply from the vincula tendinum.
Right. The tendon also requires an immaculate, smooth surface to glide. Overexposing the tendon through massive, aggressive longitudinal incisions disrupts that blood supply and destroys the gliding surface.
You guarantee severe postoperative adhesions.
Yep. You might clear the infection, but you leave the patient with a stiff, completely frozen finger. Small, carefully placed transverse incisions proximally at the A1 pulley and distally at the A5 pulley for your irrigation catheters are the gold standard.
Okay, what happens when that infection breaches the deep spaces of the hand? This occurs if a sheath infection goes unrecognized, or, say, a laborer gets a deep palmar puncture wound.
The bacteria invade the palmar space, the thenar space, or peroneal space.
The thenar eminence is the most common region for these deep space infections, right?
It is. And for palmar abscesses, your incision must be curvilinear, running from the distal palmar crease down toward the hypothenar eminence, paralleling the natural skin creases to avoid contractures.
And for the aminar abscesses,
You make a curvilinear incision along the thenar crease itself.
I have seen residents get totally fooled by a massive, swollen dorsal hand, only to find out the actual infection is buried deep in the palm. I am talking about the collar button abscess.
Well, the classic trap.
How does a palmar callus cause that kind of anatomical misdirection?
Well, you see this in heavy laborers. The infection forms deep beneath a thick, unyielding palmar callus. Think of that callus like a concrete bunker. The pressure builds, but the volar skin will not give way.
So the pus takes the path of least resistance.
Exactly. It tracks dorsally, squeezing straight down through one of the 3 web spaces.
It blows out the roof because the dorsal skin is thin, loose, and incredibly compliant compared to the palmar skin.
Right. The swelling and fluctuance are massive on the dorsum of the hand, which tricks the unwary surgeon into only draining the dorsal swelling. If you do that, you fail to recognize the palmar source of the infection.
You need both dorsal and palmar incisions to clear the dumbbell-shaped cavity.
Yes, but you must meticulously avoid cutting through the web space itself, or you will cause a crippling syndactyly contracture.
Navigating these spaces at night is fraught with danger zones. In the thenar crease, you are operating right over the recurrent motor branch of the median nerve.
Slip there and you paralyze the thumb's opposition.
Now consider the deep bursae. The radial bursa is the proximal continuation of the thumb flexor sheath.
And the ulnar bursa contains the little finger flexor sheath and the proximal palmar portions of the 2nd, 3rd, and 4th sheaths. They communicate directly via peroneal space,
which sits deep in the distal forearm, right between the pronator quadratus muscle and the overlying flexor tendons.
This anatomical communication allows a neglected thumb infection to track proximally, cross the wrist into peroneal space, and travel down the little finger flexor sheath.
This creates the dreaded horseshoe abscess.
Yes. And when you are dissecting deep to drain peroneal space, the palmar cutaneous branch of the median nerve is directly in your crosshairs. You have to be so careful.
Deep space infections are bad enough when they start from a simple puncture. But when the bacterial load is staggering-like from a human mouth, the joint itself is usually the target.
Human bite injuries.
Yeah, typically a clenched fist striking a tooth.
These are some of the most destructive infections you will ever manage.
The mechanics are entirely positional. During a fight, the fist is clenched tight. The extensor tendon and the underlying joint capsule are stretched maximally over the metacarpophalangeal joint.
Right.
The opponent's incisor punches through the skin, the tendon, the capsule, and deposits oral bacteria directly into the joint space. But when the patient shows up to the emergency room an hour later, they open their hand to show you the cut. And as the fingers extend, the skin and the extensor tendon slide back proximally.
Exactly. That sliding mechanism completely seals the puncture tract. It acts like a one-way valve, trapping the bacteria inside the closed avascular joint capsule.
And the environment is highly virulent, containing massive amounts of mixed aerobic and anaerobic flora, notably Ichanella corrodens.
Yes. Because the wound looks like a tiny scratch in the ER, patients often delay seeking care for days.
Which is a huge mistake.
Yeah.
If there is any suspicion at all that the extensor mechanism was penetrated, or if you simply cannot visualize the depth of the wound in the trauma bay, it mandates formal exploration and washout in the operating room.
You cannot guess. Because if pus is in that joint, you have a septic arthritis.
Finger joint infections present with a digit held in slight flexion to maximize joint volume, right?
Yes. There is severe pain on even slight passive movement. Joint aspiration is your primary diagnostic tool. You are looking for purulent, cloudy synovial fluid.
Let's translate those classic lab values. You will see a white blood cell count over 50,000, with greater than 75% polymorphonuclear neutrophils, and a glucose level crashing below 40 milligrams per deciliter.
Do you know why the glucose crashes?
Because those neutrophils are actively consuming the local glucose while simultaneously releasing massive amounts of proteolytic enzymes that are rapidly digesting the articular cartilage.
Spot on. Once pus is in that joint, rapid, high-volume surgical irrigation is required to literally wash away those destructive enzymes and save the articular surface.
Let's briefly contrast the human bite mechanism with animal bites. Dog and cat bites require immediate tetanus prophylaxis.
Definitely. And cat bites are particularly insidious. They are highly infectious, primarily driven by Pasteurella multicida.
Cat teeth are incredibly sharp and narrow.
Right. They create tiny, deep, needle-like puncture wounds that seal over almost instantly, injecting Pasteurella deep into the tendon sheaths and joints where it proliferates rapidly.
We have been talking a lot about saving joints and tendons. But sometimes a delayed presentation or an aggressive pathogen threatens the entire limb or the patient's life.
We need to shift to a radical surgical mindset.
Let's start with osteomyelitis.
Osteomyelitis in the bones of the hand usually stems from open, contaminated fractures or direct penetrating trauma. Interestingly, direct extension from a nearby soft tissue infection, like a pyogenic Tenosynovitis, is relatively uncommon unless it is chronically neglected.
Diagnosis relies heavily on advanced imaging, like bone scans, tagged white blood cell scans, or MRI, to define the extent of marrow involvement.
Surgical debridement is mandatory in almost all cases to achieve source control.
And if a sequestrum is present, which is a piece of dead, devascularized bone acting as a bacterial sanctuary, what do you do?
You must perform a ruthless curettage of all necrotic bone until you reach healthy bleeding margins. You pack the resulting void open.
Right. Do not attempt to reconstruct a bone defect with grafts or hardware during that initial debridement.
Never. Reconstruction only happens weeks later after you have definitive, proven clearance of the infection.
Now for the absolute true emergency, necrotizing fasciitis. This is a limb-threatening and life-threatening infection that often starts from a shockingly minor scratch or puncture.
The mortality rate still sits around 40%.
Diabetic and immunocompromised patients are at massive risk here. In nearly 50% of cases, a single organism is the driver, most commonly grouped a beta hemolytic streptococcus.
The pathophysiology is terrifying. The bacteria produce exotoxins that cause rapid liquefactive necrosis along the fascial planes, outstripping the overlying skin changes.
And the toxins cause widespread thrombosis of the subcutaneous microvasculature.
Which is why you see the classic, terrifying, violaceous discoloration of the skin. The tissue is literally dying from lack of blood flow.
You will also note bright, shiny skin, hard, non-pitting edema extending far beyond the redness, and severe pain way out of proportion to the physical exam.
The moment you suspect necrotizing fasciitis, your timeline accelerates to minutes. Early, aggressive, wide surgical debridement of all infected and dead tissue is mandatory.
You start broad-spectrum empiric antibiotics immediately, right?
Yes. And you will likely need to bring the patient back to the OR for aggressive serial debridements every 24 hours until the necrosis stops spreading. In severe fulminant cases, early amputation is the only definitive way to save the patient's life.
Heavy stuff. Let's pivot to intravenous drug abuse infections. Direct inoculation of bacteria and foreign substances into the subcutaneous tissues.
This leads to rapid, complex abscess formation. But you are not just battling bacteria.
Right. The injected drug material, the cutting agents, the acidic pH, all of it is highly caustic and causes direct local tissue necrosis independent of the infection.
These are heavily polymicrobial infections, usually dominated by resistant staph and strep species.
For a massive high-V drug abuse abscess spanning the forearm, the instinct might be to just widely unroof the entire cavity to guarantee drainage. Take the whole top off. But that is a trap, isn't it?
It is a massive trap. Leaving a huge open wound creates a tremendous reconstructive burden down the line. You turn a manageable soft tissue infection into a massive defect requiring a complex free flap or large skin grafts.
So how do you manage it in real life?
In real life, we manage large loculated abscesses differently. You palpate to find the point of maximal fluctuance. You make multiple small counterincissions along the periphery of the cavity.
Okay.
Then you aggressively break up the loculations and thread large Penrose drains through those incisions, crossing the entire cavity.
Ah, I see. This maintains dependent gravity drainage for 2 to 3 days until the purulence resolves while preserving the overlying skin bridge.
Exactly. Finally, we must discuss the changing landscape of nosocomial and resistant infections. Postoperative infections in clean, routine elective hand cases are actually quite rare.
Which is why routine prophylactic antibiotics for standard, quick trigger finger, or carpal tunnel releases are absolutely not recommended.
Right. You only use perioperative prophylaxis for operations involving permanent implants, hardware, entering bone or joint spaces, or complex cases that exceed 2 hours in tourniquet time.
When post-op infections do happen, Staphylococcus aureus is the usual culprit. But the massive paradigm shift is methicillin-resistant Staph aureus, or MRSA.
We expect it in the hospital, but the massive spike is happening in the outpatient setting.
We are seeing case series of fulminant community-acquired MRSA hand infections in patients with absolutely zero previous risk factors. No recent hospitalizations, no IV drug use, no incarcerated contacts.
This completely changes the landscape of empiric therapy. It makes routine wound cultures absolutely mandatory before you initiate antibiotic therapy, so you can actually guide your treatment when the empiric regimen fails.
You have to intimately know your hospital-specific antibiogram.
You really do.
Let's bring this deep dive into the literature together. The fundamental surgical truths of managing hand infections remain constant, whether it is 2 p.m. or 2 a.m. You need an early, accurate anatomical diagnosis. You drain the closed spaces widely and intelligently, respecting the structural danger zones. You get your cultures early, you meticulously debride all necrotic tissue, and you leave those wounds open to drain. Never close a heavily infected space.
It all comes down to respecting the complex anatomy and understanding the pathophysiology of pressurized closed spaces. Release the pressure, remove the necrotic burden, and preserve the gliding surfaces.
But I want to leave you with a final thought to mull over during your next call shift. Considering this alarming, undeniable rise in community-acquired MRSA in patients with absolutely no traditional risk factors, will our standard practice of using targeted, narrow-spectrum empiric therapy for routine hand infections soon become entirely obsolete? Are we rapidly approaching a reality where surgeons will be forced to treat every minor felon and paronychia as a potential superbug right out of the gate?